Hello, welcome to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor at JAMA Network Open. Of course, if you're following along live, please send us your questions or comments and on Twitter at JAMA Network Open or in the comment box under the YouTube or Facebook video. Today, we're going to be talking about modeling contact tracing strategies for COVID-19 in the context of relaxed physical distancing measures. We've got two authors today, Alyssa Belinsky and Josh Solomon. Welcome and thanks for joining us.
Thank you.
Great. If you two could start, just give us a little background on who you are and why you did the study.
So my name is Alyssa Belinsky. I'm a PhD candidate at Harvard in the health policy program. And we were interested in this study because most of the measures right now that are employed to prevent COVID-19 outbreaks are population level measures. So these include interventions such as limits on gathering size or closing high risk venues like bars and restaurants. And what that does is it breaks chains of transmission so that instead of each person who has COVID-19 on average infecting 2 or 3 other people with what we call an R naught of 2 or 3, they ideally will then infect less than 1. And contact tracing is a strategy that ideally promises to make those measures less broad, affecting the whole population, and more targeted on people who are infected and their contacts who they were likely to infect. And so we were interested in trying to think about how these targeted measures could substitute for population-based measures and to what extent under different conditions.
Well, I'll go ahead and introduce myself as well and jump in. My name is Josh Solomon. I'm a professor of medicine at Stanford University School of Medicine, and I direct the Prevention Policy Modeling Lab. Just to add to what Alyssa said, contact tracing is a strategy that is kind of core public health activity that's been used for decades, 100 years, in a lot of different infectious diseases, from sexually transmitted infections. It was important in smallpox eradication. It's used in TB, and more recently in respiratory infections like the 2003 SARS outbreak or the 2009 H1N1 outbreak. And with respect to COVID-19, if you look at any of the countries that have been successful in responding to the virus, every single one of them had contact tracing, at least as part of their strategy.
Yeah. And I think an example for me that really showed how contact tracing works is what happened when we started seeing outbreaks in Major League Baseball, where they basically started following the players, who they were around, who else they could have gotten sick, that sort of thing. So back to your paper here. Tell us what went into your model. What were each of the branch points, and what do they mean, and how much do they represent where we are right now?
Yeah, so what we were trying to do was model the full pipeline that goes into successful contact tracing. And there's several different pieces that play a role here. So the first is testing, specifically testing cases in the community and identifying what are known as index cases. And then once those index cases are identified, we are able to track or not track their contacts. And those index cases and their contacts have a certain level of success in quarantining or isolating if you're infected, which prevents them from spreading the virus. And then we sort of go through generations of this. So we say index case identified in the population, then we look for their contacts, and then ideally you would trace the contacts of those contacts and so on. And in terms of where we are right now, I think that we tried to capture a couple of we tried to capture a wide range of realistic parameters that represent sort of different areas and settings. So we tried to vary sort of the proportion of cases in the population that are symptomatic, that are going in for a test and being detected, how well people are able to stay home when they're either infected or they're the contact of an infected person, and the proportion of testing that goes in to sort of identify these people sooner.
Okay, great. And I see, the one question I want to clarify for myself, you in the research letter, you talk about the percentage of symptomatic infections detected in the community. Is that a level of community prevalence, or is it what fraction of overall cases are actually being tested for?
It's what fraction of overall cases are actually being tested for.
Great. Okay. And then I found what was one of the things I found really interesting here was the varying levels of the efficacy of quarantine and isolation, which you have from 30 to 90%, which frankly, based on my casual observations, what I see with people, what happens when I talk to people at work in the ER, when we talk about how they have to stay at home. And those are pretty plausible numbers. Where do those come from, and how do they affect the model?
Yeah, one of the really important things is that those numbers really represent two key ingredients. The first is the timing of the outreach to the contacts and when we're able to find them and be in touch with them. And so if there's a long lag, as we've been seeing in some places in the turnaround time to get test results, that creates lags throughout this entire pipeline that Alyssa described, including meaning that if we reach contacts, we're reaching them pretty late since the time that they were exposed or infected. So part of the reduction in efficacy of quarantine isolation captures that. For some of the contacts, we may be reaching them after they've already had an opportunity to transmit to others. The other part is what we would think of as adherence to the recommendation, either to quarantine for somebody who's been exposed or to isolate for somebody who has a confirmed diagnosis. And there, as you've picked up on, that can be a really hard thing for people to do. I would say especially for people who just have the suspicion of infection as opposed to a confirmed diagnosis. And so when we think about efficacies ranging along that pretty wide range, up to 90% in a very good example, but as low as 30% or lower, it's really reflecting the combination of those two factors.
And Cole and WPA Psychiatry have joined us. Welcome. We are talking about modeling contact tracing for COVID-19. So looking through figure 2, that's kind of the meat of your results. You can just see as you vary each of these steps in the model, there's just a huge difference in how much the RT changes. Can you talk about maybe where you think we are and how we can get to a better place with these?
Yeah, maybe I'll start and Alyssa will augment. But kind of in the big picture, if you look across all those dimensions that we're examining, so starting with how much of the currently symptomatic population are we reaching, going through whether we are doing a good job or not finding and making contact with their contacts, and then finally the isolation and quarantine efficacy. If we're doing a poor job on any of those, again, thinking about the pipeline metaphor, if we've got leaks along any of those junctures, it really, really reduces the potential impact of the program overall. So kind of high-level numerical summary, if we are both detecting fewer than half of symptomatic infections in the community and reaching fewer than half of their contacts, we're unlikely to make an impact of more than a 10% reduction in the overall transmission. So that's kind of on the low end. As we move up from there, we start to see where the potential for substantial impact exists. So if we go from 50% to, say, 70% on all of those factors, case detection, successful outreach, and adherence, then we're in the neighborhood of about a 20% reduction. And if we can get those really high, say in the 80 to 90% zone, then we could be reducing overall transmission by 30 or 40%. In terms of kind of where we are in contact tracing programs around the country, right now, I would say most of the programs are on the lower end of that spectrum. And a big problem is that we don't have data systematically from every program, and so it's quite piecemeal. But where programs are reporting out, we're certainly closer to the 50% zone or lower in many of the programs that do report data as opposed to the 90% zone.
And you talk here about use the RT as the number, and most of the, I think, lay news articles we see use R naught. Can you talk about the difference between those two?
Yeah, so R naught is a very technical term that refers to the number of infections generated by dropping one infected person into a completely susceptible population. So into like a population where no one has been infected and everyone can get the disease. It's also important to know that it's a combination of biology and behavior. So it has to do both with how much that person is likely to interact in a population or an average person would interact, and how sort of infectious the disease is from in different types of contact. But over the course of an epidemic, things start to change. So the first thing that changes is that some people have been infected already and they can't get infected again. And so that tends to reduce the number of people who can be infected by an infectious case later on in the epidemic. And secondly, and I think more importantly in the case of COVID-19, we start to apply measures to prevent infection and to prevent transmission. And so the number of infections that are generated by someone at a certain time, which we'll call time t in the epidemic, by that average infected person is called RT. So if, today the average person who has COVID-19 in the US infects one other person, we would say that RT is 1.
Okay. Great, thank you. Claudio Corradino and Pat Albinsky have joined. We're talking about modeling contact tracing for COVID-19. So really, as we wrap things up, what's the kind of takeaway? Where do we need to go with contact tracing, and how is that going to magically fix everything if it can?
Well, so right now there's a lot of obstacles to effective contact tracing. There's bottlenecks that we talked about in terms of accessing testing and slow turnaround time. Health departments remain underfunded. And probably the biggest obstacle is that the case numbers and the ongoing transmission is just very high right now, and it's hard for contact tracing programs to keep pace. That said, contact tracing, sort of in the way that we started this program, is almost certainly going to be an essential component of an effective response when we can get there. Contact tracing can make a big impact in terms of reducing transmission, and it doesn't need to be perfect to make an impact, but it's not going to be a magic solution. I think that's probably the most important thing to emphasize. Contact tracing really does need to be embedded in this pipeline that starts with good testing and moves through tracing and on to measures to help support people being able to quarantine and isolate. And this strategy of testing, tracing, and isolation needs to be part of a multi-pronged response that includes masks and includes distancing and includes strategies to protect the vulnerable. So it can make an impact, doesn't have to be the optimal program to do so, but it's not going to erase the epidemic on its own.
And if anything, just looking at these numbers, it's every little bit seems to help. There's so many different factors, and increasing, turning any of those dials up seems to make a big difference in the results. So unfortunately, we're in a place where we seem to only be able to do better with our public health efforts right now, to put an optimistic spin on it. We'll really appreciate the work you've done. Oh, sorry, Alyssa, you go ahead.
I was going to say, I think that the one key point I would add to that is that right now, it's also just very hard to know how well we're doing with contact tracing. And so part of making it better and understanding where the weak points are is trying to ensure that contact tracing programs around the country provide metrics about things like the time from development of symptoms to development of testing to reaching contacts and the number of contacts that they can reach. And then the fraction of cases that are unlinked to cases that they know about. And I think that all of that sort of can help us really have a better understanding of where we are and the types of programs that are doing well and how we can help programs that are struggling more.
Well, great. Well, really appreciate the work you're doing here, and thank you so much for joining me today to talk about it. We are going to be back next week, Tuesday, September 1st at 3 p.m. Central Time again. So please join us again. You can get this paper and more at jamanetworkopen.com, where everything is free to read and download. And we have new content coming out every weekday at 10 a.m. Central Time. So please take care and be safe.
Thank you.